I'm Harriette Van Spall, Associate Professor of Medicine from McMaster University, and I'm so honored to have with me Professor Milton Packer from the Baylor University Medical Center in Dallas, Texas. And we are here at ESC 2023 to just talk about the meeting, some of the take-home points, and opine about what we've heard and read. So welcome, Milton. Thank you for
Harriet,
joining us.
I'm so delighted. We always have wonderful conversations and discussions, and I'm really looking forward to this.
And I'm looking forward to learning from you. So
let's have fun.
Tell us, we had these big guidelines, heart failure guidelines, updated at this meeting. What are your thoughts about them?
Well, let's begin with the fact that for the last 20 plus years, I have been extremely skeptical, even cynical, about heart failure guidelines. And the reason is because heart failure guidelines involve a process which is partially scientific and substantially political. And the whole goal is to reach consensus across extremely diverse views, but of course, entirely determined by who's on the guideline committee. And I always say that I am so appreciative of their efforts. I admire their dedication, but the guidelines represent the opinions of the authors, and they do not represent biblical scripture. Is there really a difference between 1A and 1B, between 1B and 2A? Are these distinctions without a meaningful difference? And so here at ESC, they introduced an update. And the reason they introduced an update is because the guideline process is so complicated that the full process can only take place every 5 years or so. And things happen during that 5-year period of time. And during that, so they say, well, we ought to, during the mid-cycle, produce an update. And so they issued an update, and the update is not intended to be transformative. This is an update that's simply, probably the major change was it recognized that SGLT2 inhibitors were a effective agent in patients with heart failure and preserved ejection fraction. And in the same breath, these guidelines said, we don't know if the term heart failure and preserved ejection fraction should exist.
And yet the nomenclature stayed the same. I had anticipated a move towards LVEF as a continuum, or at least less classes as a next step towards that move. And yet we see the same 3 categories that aren't really informed by evidence, but perhaps reflect some of the recruitment strategies, inclusion criteria in our historic trials. Tell me, what do you think about the recommendations made for patients with heart failure and mildly reduced ejection fraction?
So the concept that there is a middle category, heart failure with mildly reduced mid-range ejection fraction, however you want to put it, is a historical artifact. It's not real. It encompasses patients with ejection fractions of 41 to 49%. Okay, I have a patient today has an ejection fraction of 44%. And if I want to make sure that they do not have the diagnosis of heart failure with mildly reduced ejection fraction, all I have to do is repeat the ejection fraction next week.
Right.
And next week, they will either have a reduced or a preserved ejection fraction. And I mean, how many people have an ejection fraction between 41 and 49 constantly forever? And the answer is no one.
Right. And so what did you think about SGLT2 inhibitors as the only class that's received a class 1 recommendation? The other pillars have received class 2B recommendations for that 41 to 49% EF group. I was surprised. Were you surprised?
I thought it was interesting.
Yeah.
But in all honesty, we have data with ARNIs up to 60%. We have data with MRAs up to 60%. We have data with ARBs, angiotensin receptor blockers, up to 60%. And the guidelines, to their credit, said, we think that the next formal guideline, we will have only 2 categories. We will have a category called heart failure with normal ejection fraction, so HFpEF, which will be cut at 60, not at 40, and that everyone below 60 will be heart failure with a reduced ejection fraction. And for those patients, we will have our typical 4 pillars. But what's so interesting is that in the patients with ejection fractions of greater than 60, 65%, SGLT2 inhibitors don't work either. So those patients are unbelievably interesting.
They are, and complex, and we don't know the mechanisms of disease and what we're treating in that category, in my opinion. So there's more knowledge to be gleaned in that area, I think. It's an untapped need.
It's really untapped. The most intriguing hypothesis is that these patients have a form of pericardial constraint and would benefit from pericardiectomy.
Oh, you think?
This has been shown in animal studies and now in a pilot trial. So it's a hypothesis. Is it applicable to the entire group of individuals? Remember, these are elderly women with hypertension with very, very small ventricles. And not thick ventricles, small ventricles. And it's really, they really do have a shift in the left ventricular pressure volume relationship that is very difficult to explain and might represent pericardial disease or infiltrative disease. We'll see.
What were your thoughts about the HFpEF trial? That's certainly been an exciting trial.
Well, we have known that obesity is a major driver for HFpEF. Well, and I will define HFpEF for purposes of this as greater than 50%, just to make it easier. And what is the prevalence of obesity in this patient population? Well, it depends on how you define obesity. And you can define it as body mass index, and that sort of really doesn't work. It really doesn't account for skeletal muscle mass. It certainly has enormous regional variations, doesn't apply to Asia. There's gender differences. It's very, very complicated. And so I really like to think of this not as obesity, but as visceral adiposity. And visceral adiposity means fat around your organs as opposed to fat, subcutaneous fat, because this fat, visceral fat, is pro-inflammatory. This visceral fat stimulates a systemic inflammatory response, which is transduced into the myocardium by epicardial fat. And therefore, visceral adiposity drives HFpEF. What percentage? probably about 80 to 85%. So if you were to eliminate visceral adiposity because of a drug that induces weight loss, and by doing so would shrink not only fat here, but fat around the viscera, then you might think that inflammation would be reduced and that the heart would work better and people would feel better. And that's what they showed in HFpEF, a remarkable trial. Most intriguing finding, of course, wasn't the improvement in KCCQ or the increase in 6-minute walk. It was the fact that the number of heart failure events was 12 in the placebo group and 1 in the semaglutide group. Now, that's a very small number of events, but it is a very striking difference. It is something we really want to see in other trials. And fortunately, there are a lot of trials right now with GLP-1 based drugs in order to reduce visceral adiposity in people where that is driving heart failure with a preserved ejection fraction. And some of them are event-driven trials. We will know the answer to that in the next 15 to 18 months.
Yeah, and we should point out that these heart failure events weren't part of the primary outcome, but a remarkable difference in heart failure events.
Yeah, and would mean that trials that are now powered for events might produce some interesting results.
Absolutely. Tell us about your thoughts on the Quest trial.
So Quest is such an interesting trial. Quest is probably the most unexpected result in this entire meeting. So Quest was done entirely in China based on a Chinese herbal medicine that had been used in heart failure for centuries with all sorts of feelings that it worked. But what is it? It is a mixture of 11 different herbs, sometimes 14, sometimes 6, done at different concentrations. In different parts of China, they have different variations of this remedy. They decided to standardize this, put it into capsules, asked people to take it 3 times daily on top of existing treatment for heart failure. And initially, in a pilot trial, showed a remarkable reduction in end-terminal proBNP. And they said, okay, well, now we can do an outcomes trial, even though it's an herbal formulation. And so they enrolled over 5,000 patients with heart failure preserved ejection fraction, taking actually reasonably good background therapy, but almost no SGLT2 inhibitors, and randomized them to the herbal remedy. We'll give it the name of QXQL, which is what they, initialized it for, or placebo, and followed patients for an average of 21 months. Event-driven trial, and showed a 22% reduction in the risk of cardiovascular death and hospitalization for heart failure, and succeeded in reducing each component to a statistically significant degree, although with a greater effect on heart failure hospitalizations than on cardiovascular death. But a really impressive result, event-driven trial with a drug that no one in the West knows about. No one in the West understands the history of it. No one understands what the mechanisms are. There are mechanistic papers with this herbal remedy, but they're not strong papers.
Right. So to play devil's advocate, I'm going to ask you 2 questions. Do you think we're biased towards Western ways of delivering medicine and against some of these Eastern approaches that include herbal therapies? And do mechanisms of action matter? Should we care? What are your thoughts on those two questions?
So, are we biased? Yes,
Yeah,
we
I
are
think so.
biased. Okay, but we are not ignorant. If someone shows us that something works, we would be very foolish not to pay attention. So, yes, the bias is there, but the bias only persists for as long as we remain skeptical. So what is the basis for skepticism here? Well, the basis for skepticism is your second question, which is, does the mechanism of action matter? I mean, we don't know the mechanism of action. Does that matter? Well, there are a lot of people who say we don't know the mechanism of action of SGLT2 inhibitors. Does not matter. Well, we have 13 major large-scale trial with SGLT2 inhibitors, overwhelming amount of data. People will continue to argue the mechanism of action for a long time. And
here we are.
And the new guidelines say for everyone, regardless of ejection fraction.
Yeah.
So, but there's a more important human question that you're asking, which is, do physicians practice evidence-based medicine or story-based medicine? So evidence-based medicine means, you know that it was a good trial. You know what the primary endpoint is. You know the hazard ratio. You know the confidence intervals. You know the p-value. That's evidence-based medicine. Most physicians don't know that. Most physicians can't remember it. Most physicians don't want to remember it. What physicians want is they want a framework, a conceptual framework where this drug makes sense based on their knowledge about how the body works. So in order to get people to use most drugs, you have to give them a story. And most of the time, the story is a mechanism. Why do beta blockers work? Because the sympathetic nervous system is evil and we have to get rid of it. Why do ACE inhibitors work? Same thing. Why does spironolactone and pleuronone work? Because all of these bad things are overactivated and we're getting rid of it. And is that how they work? Well, we think so. But the truth is, if you ask most people, tell me about the 3 large-scale beta blocker trials that showed that they worked. Tell me about the 2 MRA trials that show me that they work. Tell me about the 2 ACE inhibitor trials. And the answer is no. But we know that sympathetic nervous system is bad, renin-angiotensin is bad. But it is a conceptual framework that drives adoption. And so physicians are like all human beings. And all human beings are like children. We want to hear a story.
Right. We're at our core rational, and we like to understand how things work.
And if we don't, we will make up a story and believe in it.
And that story could be laced with cynicism and this disbelief that some of us feel about the Quest trial.
Of course. And you know something? That cynicism, that skepticism is healthy.
It drives science.
It drives science. It drives replication. It drives mechanism of action story. I mean, the most maladaptive response to a scientific presentation that surprises you is acceptance.
Absolutely.
The most adaptive response is skepticism. Every major change in the way we think about the world, science, medicine, was greeted with skepticism, often for decades and centuries.
Right, and we're both parents, and I think of it in terms of skill building. You know, it's a very important skill to train and to have kids encouraged to demonstrate informed skepticism. Don't take things at face value, dig deeper. And here we are doing the same.
You're doing the same thing.
Yeah.
And if we didn't teach our children that, then their generation wouldn't change the world.
Right. They'd be prone to
They would just
believing.
keep it the way it is.
Absolutely.
And God, that would be unbelievably awful.
Absolutely. What do you think the next big thing is in heart failure? What are your tell me 3 predictions in terms of where we're headed?
I think I'll tell you what I would like to see happen.
Okay.
And I'm not so it's hard to call it a prediction as much as a wish.
Okay. Milton's 3 wishes.
One wish.
Okay, just one.
Okay. I could use the wish to ask for more wishes, but that would be cheating. So,
And we'd be here all night.
yeah, exactly. So the wish is that we seriously invested in a non-physician-based workforce to take care of patients with heart failure. A workforce that would be dedicated to one disease, that would care for millions of people who are not getting optimal care right now, and who would be informed by the evidence or our interpretation of the evidence. But at least it would be implemented. And I don't think physicians are positioned well now in the way that our healthcare systems and enterprises are structured. I don't think they're well positioned to take care of millions of people and go through an incredibly complex menu of drugs, devices, testing. Most physicians who are, general physicians, physicians who are primary care specialists, cardiologists, don't want to spend all of this time. This is an incredible investment in individual care. We have to develop a workforce to do that.
And you specified heart failure care. So do you see care in the future as remaining organ specific and disease specific? Or do you think we're going to rise to person-centered care because the same patient with heart failure has chronic kidney disease, lung disease, cognitive impairment? Who's taking care of all these other organs?
Yeah, that is the Achilles heel of my wish.
Right. I didn't want to point it out, but
yeah,
I thought I'd throw that in there.
It's really a major limitation. The proposal sounds great. You say, oh, this is great. We're going to start it tomorrow. And the answer is you just hit on the major weakness, because, does that mean that a patient with heart failure and 5 comorbid conditions has to now go to 5 different subspecialty clinics? And so now I am fearful that not in the not too distant future, I will go into a office for a medical visit with a medical complaint, and a robot will come and ask me questions, and the robot will have amazingly wonderful emotional connection. The robot will ask me how I'm doing, and the robot will say, am I having a good day? And they may even ask me about my family. And the robot will go through a very formulaic sense of all of the organ systems, might even take some blood tests, might analyze them for 10,000, 40,000 different proteins, might take an electrocardiogram and determine in sinus rhythm whether I've had atrial fibrillation or not through an AI-generated program. And I will now have comprehensive care, which doesn't involve a human being. So I guess I could have a non-physician workforce by having a non-human workforce.
Right, and your description is not that far from reality. You know, we have, you can have an AI romantic partner now who argues with you the way our usual partner would and says all the things partners do. And we have the capacity through generative AI to have some of these roles fulfilled. And I do see an integration between what you describe, such that clinicians would have more information at the point of care. It could make care better. There's pitfalls, and it's in managing all of the potential in a way that remains patient-centered, I think, that the solution lies.
Will physicians just do procedures?
I don't think so. You know, I think that when I'm ill, I'll still need you to hold my hand.
I'll be there.
And give me a hug.
I will,
and sort out how I feel about my healthcare journey, what my values are, preferences are, so that...
Do you think a robot can do it better than I can?
Not you.
Oh, I understand.
But perhaps a robot can do some of that better than some physicians, but not Milton Packer.
Okay, but would you, when you went home, would you know the difference between a human and a robot?
That's a whole different question. How do you know the truth? And how do you discern reality?
Robots are capable of empathy.
They could be, yes.
And so the whole concept, and here's the thing that I find the most interesting. Would adherence to recommendations about drugs, diet, lifestyle, would there be greater adherence if it came from a robot than from a doctor? And you know, the answer might be yes.
We need to test the hypothesis.
It could be
right.
that patients would actually follow to the letter a advice that they thought was somehow unbiased.
Right.
Some algorithm of great wisdom. I still worship the days when a giant of medicine would walk in, listen to a patient's chest, hold their hand, and know exactly what the diagnosis is without doing a single non-invasive test. But those days are gone. And even if we could bring them back, there are too many patients to care for. So, how many wishes do I get now?
As many as you want, Milton. You get as many as you want. But I think you're pointing out to the fact that when you say there are too many patients, we need to move towards prevention, primordial prevention, to manage the burden of disease and the way we deliver care. And you're also talking about the potential of harnessing the power of digital health, artificial intelligence, but in a way that remains humanistic, but extends our reach, gives patients the perception that there's time invested in the information they have to offer, and makes us better in some way, either more efficient, more tailored in our approach, but remain in that circle of care. I hope we all have jobs.
I really hope so, but I will give you my final wish.
Please do.
I want to be able to find a way that patients would trust the healthcare system again. Because if they do, then everyone benefits. But there is an enormous amount of skepticism. There's an enormous amount of pushback. It's all because the trust that used to dominate the physician-patient relationship got eroded, was broken.
Absolutely.
And if there's any priority that we give to changing things, it has to be to restore trust.
Right, and then trust is really the core of every kind of relationship,
Right.
isn't it? And I think we need to take ownership for some of the reasons why we are mistrusted by patients. It takes journeying through the lens and the shoes of a patient to understand why some of that trust has been lost. And we all have a lot of work to do to regain that trust, as you say. Thank you so much for
Thank
being
you.
here. We started with ESC and we ended with trust, and that's why I
Exactly.
love
It's
talking
great.
to you.